Just to briefly go over the neurobiology, because I think it's a really helpful way to kind of conceptualize all patients with addiction. And this neurobiology looks like it's true for all substances of abuse, alcohol and all the drugs, but also for behavioral addictions. And that research is newer, but all the evidence so far is showing that this system and this circuitry is valid for kind of all of these disorders. So when we classically think of addiction, we think about the reward pathway, which is from the ventral tegmental area. You can see right here in the midbrain. And then projecting to the nucleus accumbens, there's dopaminergic projections that land in the nucleus accumbens. So at baseline, we kind of have a steady dopamine level in the nucleus accumbens. Whenever there's a spike, it tells us that this is pleasure, and this is something that we should pay attention to in our environment. And what we've learned is that substances of abuse cause a spike in the nucleus accumbens like that, but it's a super physiologic spike, so it's bigger than it should be. And that's kind of associated with that euphoria or that rush that people get when they use a drug of abuse. And so it kind of hones in their brain to tell them in a very primitive survival type way that whatever you just did was important and you should try to repeat it. Because in nature, this system is used all the time for natural rewards. So food, sex, affection, kind of all the good things that we like in life also spike your dopamine in this area. The problem is that drugs of abuse give you a bigger spike. And so that's why you get that euphoria and that rush from it. And this is true for any of us if we are to take a drug of abuse, it would spike in the same way. You can see here just some graphs to show you the magnitude of this. In the upper left is morphine. So if your baseline is around 100% and you take morphine, it's going to spike it to 200%. You can see cocaine is a little bit over 300%. Nicotine is over 200. Food and sex would be more around like 150 or so. So these are higher than food and sex. And here's crystal methamphetamine. You can see the spike is to 1,000%. So when people use IV crystal meth, and they say it's the best thing they've ever done, they're not kidding. And this is also why it's a good idea not to use crystal meth, so that your brain doesn't have an idea and a benchmark of 1,000%. For people in recovery from crystal meth, a big part of the conversation is that life is not going to be as exciting or fun as it was when you were doing crystal meth. And so if you have a counselor or a therapist working with the person and kind of saying, no, regular life can be just as good, then they know that that person has never used crystal meth. So a good PSA for yourselves and your children, if possible, to avoid it. Pleasures that we should not know on this earth, probably. In terms of acute drug effects, so everything that I've been talking about here is stuff that happens very acutely. So if you expose your brain to these drugs, you're getting these spikes, and it results in protein changes that last only on the order of hours to days, and then your brain kind of goes back to homeostasis. So your brain very quickly will start to downregulate dopamine receptors, less dopamine will be available. Your brain knows that it's getting too much dopamine with these bursts, so it tries to come back into balance pretty quickly. And what was kind of interesting in the research was that none of this stuff with the reward pathway explained why people would get compulsively addicted to drugs and why they would give up their children, their homes, not care about anything, be like dirty in the street, going to the emergency room. None of that explained it from this reward pathway idea. Because this is really that old idea of kind of pain pleasure, that people who are addicted are just seeking pleasure and they don't want to get up and go to work like the rest of us, and that people are trying to avoid pain. But this pleasure pain principle really doesn't hold out when a person is more severely addicted. And I'm sure you've had the experience of talking to somebody who is, and they'll say, I hate my drug of abuse, whether it's cocaine or whatever, and they're desperate to stop using it and they don't even like it anymore, but they're not able to do so. So what we've realized in the last 20 years is that there's a whole different circuitry that's involved. And this is just that idea of that end-stage drug user. So with repeated use over and over, you start to have these longer acting proteins that get activated, and these are ones that actually are transcriptional regulators and make long-term changes in neurotransmitters and those types of systems. And what we realize is it's actually switching to a glutamate-based system away from dopaminergic. So all of the dopamine stuff you hear about is just that very initial pleasure when you first start using, and then your dopamine system kind of tamps down. You never get that same reward again. People will talk about chasing that high, that first high, and that's the reason, because your dopamine system was so pristine when you first started. As you get more and more addicted, you switch to these glutamate circuits, which actually end up starting in the prefrontal cortex and coming back to interact with the limbic system and with the nucleus accumbens. And so you get a whole kind of dysregulation that's happening in the prefrontal cortex part of your brain. And that's why we start to see impairments in decision-making and judgment and rationality, because the prefrontal cortex is really the part that makes us human. It's the part right behind your forehead. It's your personality, your everyday interactions with people. You're making kind of reasonable decisions, saying, I'm going to do this, I'm not going to do that. Whereas the primitive stuff we've been talking about in the nucleus accumbens, that's more like your limbic system and your drive forward, almost like your id in psychological terms, right? Kind of your impulses and desires. And as you move through in addiction and you start to have this glutamatergic circuitry developed in the prefrontal cortex, it weakens your willpower and your impulse control areas, and it makes your limbic system stronger. So it kind of shunts all of your behavior towards satisfying what your limbic system would like to do. And I think that's the biggest message to really get across for these people with addiction. It's a little hard to see probably, but these are just some of the brain areas kind of mapped out. And the upper part with the green circle, that's the part of your prefrontal cortex that goes offline. So it becomes much less strong in terms of inhibiting other parts of your brain. It's very weak. And the red circle area is the limbic system, but also associated places as well. The basal ganglia, so motor circuits in terms of people having habits of walking by a certain corner to get their liquor or to buy their crack. People will describe sometimes that they kind of just on autopilot ended up walking themselves right back to that place or driving themselves back to where they could get their drug. And that's the basal ganglia that's been activated. The amygdala, which is your fear center, the hippocampus, where you have long-term memory storage. Some of these more medial parts of the prefrontal cortex, the orbitofrontal cortex, which is social cognition, that gets co-opted for drugs of abuse. And so it's kind of this perfect storm where your limbic system is really running the show and telling you, go seek this drug and do all these things, whereas your prefrontal cortex really becomes offline. And so you actually don't have the impulse control or the willpower to stop yourself from doing these drugs of abuse. So once a person's brain looks like this, and I think I have a more dramatic slide just to show you, there's been a lot of research done on this in the past few decades, and out of all of psychiatry, this is one of the areas that we actually understand the most about the biology of what's happening in the brain. So you can see on the left, that's kind of a balanced, non-addicted brain, whereas on the right, all these systems are now out of whack. And you have, right in the center, that green square, you have a much larger component of your nucleus accumbens. It's really controlling your behavior at this point. So what do people think is the way to get your brain from the addicted side back to the non-addicted side on the left? What would be the best way that we could do that? Yes, so abstinence is the key. Was that you, Sandra? Okay, it doesn't count because she took our addiction medicine executive fellowship, so you're not allowed to answer. No, just kidding. So abstinence is absolutely the key. You have dysregulated circuitry, and the longer you're abstinent, the more your brain is going to shift back to the left side, just because it always wants to go back to homeostasis. It's always trying to get back to the left side. So working in the prison system, you actually have a perfect opportunity. If your patients are not able to get drugs, which I know is a whole difficulty and a whole separate issue, but if they're actually able to be abstinent in prison, it is a perfect time to start staging interventions because their prefrontal cortex is going to be much larger and much more online. And when you're working in therapy with a person, you're engaging with their prefrontal cortex. So that's why when somebody is severely addicted on the street, you can have a great therapy session with them, but they're going to go right back out and keep using because they don't have that circuitry to give them the willpower to stop. So you can have people in prison who their brains look like the right when they come in, they start looking like the left side the longer they're there, and even if they don't initially have the motivation, they can just naturally develop it over time because their prefrontal cortex is becoming much more regulated. And they're going to have different thoughts, attitudes, behaviors. They're going to walk and talk differently, even if you gave them no intervention at all. The problem, of course, is if you don't do anything about substance abuse and they get discharged or released and they go back to their home community, all their friends are there. It's very easy for them to fall back into it. So they don't have nearly the level of craving that they had when they first came in. They should have almost none. But if you put them back in that environment, almost everybody is going to relapse. So before release and all throughout their sentence is a perfect time to start intervening and getting them motivated because it's this great opportunity. And all the drugs, all the medications, I guess they're drugs as well, that we use for people for addiction issues is all really to help them with cravings in order to be abstinent, to let their brain heal. So this really is the gold standard treatment, is just to kind of lock someone away. And that's the idea of an inpatient rehab, right, which is similar to incarceration. And for all the opioid epidemic that we have right now and all the problems we see with addiction in our society, we actually don't need any new treatments. We don't need new technology or new research. We kind of understand this and we know what to do. The problem is access to treatment and access to aftercare rather than the technology. We actually know what to do at this point. And this is just to show you that you can think of your addicted patients just like adolescents, which I'm sure some of you have adolescents, who are super frustrating, difficult, irrational. You want to shake them, and they're always doing something that doesn't make any sense. And they also don't have a fully functioning prefrontal cortex. It takes until you're 25 or 26 to be fully myelinated in that area. And so if you kind of shift how you think about people who are addicted and picture them much more in this model, then you don't get frustrated. You don't get into like a one-on-one battle of the wills or angry at them that they've relapsed. You kind of expect them to relapse, and then you're pleasantly surprised if they don't. And a huge part of addiction, of course, is shame and kind of stigmatization. So the more open and kind of cheerful you can be as a provider and approach them in a very kind of open-minded way, it's so helpful when you're working with addicted patients not to get caught in that confrontational style of treatment. So as I mentioned, this goes for all drugs of abuse, including opioids that we'll talk about. You see the same dysregulation. And just as a very quick overview, opium is the milky white latex from the poppy plant. And people are always interchanging opiate and opioid, but just so you all officially know, opiate is what's naturally occurring in the poppy plant, which is only morphine, thebaine, and codeine. Everything else is chemically derived from that, and all the chemical derivatives are called opioids. And naturally occurring opiates are also included in the opioid category, just to make it extra confusing. So the technical term should almost always be opioid, but you see it interchanged with opiate all the time, which I think at some point it's not even going to matter. It could just be either. Of course, we have both internal and external opioids. Our internal opioid system keeps us regulated. It makes us feel content. It gives us a certain hedonic tone so that we kind of feel like all the aches and pains of life aren't bothering us too much, both physically and emotionally. As you sit here in the chair, I'm sure some of you have a certain pain in your leg or some back pain, or you have a bad feeling from a fight you had with a partner this morning or whatever it is. And opioids kind of help you regulate that and numb that a little bit. It's kind of your natural painkiller to be able to kind of face your day and go about what you'd like to do. Which is why when people are in opioid withdrawal, it's so excruciating for them, which we'll talk about in just a moment. Because of where the opioid receptors are located throughout the brain, there just happens to be a lot of them in the brainstem, in the medulla, which is our breathing center. And so because of that quirk, if you have too much external opioids, you can end up suppressing your breathing, and that's how people die of an overdose death. So it's kind of very simple in that way. Alcohol is a very complicated drug that interacts with multiple receptors. Opioids are just hitting the opioid receptor, and the reason you die is because they suppress your breathing. Other than that, opioids are actually not that medically bad for you. People are on methadone for years and years with very little medical side effect. A little bit of osteopenia, and sometimes it interferes with your gonadotropins and some of your sex hormones, but it's very mild compared to the amount that we're talking about and the duration of treatment. So something like alcohol is far, far more toxic for you. Opioids are only really bad because they kill you so easily. There's a whole bunch of different opioids, as I'm sure you all know. We won't go too far into that, and I'm sure everybody has an idea about opioid intoxication. One of the things that not everybody realizes, opioids actually stimulate what's called the area postrema. It's a certain part of your brain in the more primitive area, and that's your area for nausea and vomiting. So a lot of people, when they first try opioids, they'll describe that they threw up or felt really nauseous, and often they had a peer group that was using, so they pushed through it and they kept using, and then they got addicted subsequently. But a lot of people have a kind of nauseous or vomiting reaction to opioids when first introduced. And then they do cause pinpoint pupils. We mentioned the respiratory suppression, and they're incredibly effective pain relievers, as I was mentioning, both physically and emotionally. And so they help people when they're rageful, when they're sorrowful, when they're happy, if they want to be less happy. They kind of numb everything, and they've been used in that way for centuries and centuries. I think I have a slide on that. Opioid withdrawal is, out of all the substances, it's the most physically uncomfortable one, the most subjectively uncomfortable. So we all know that alcohol and benzo withdrawal are the ones that are going to kill you, but opioid withdrawal are the ones that the doctors want to kill the patient for them because they drive them absolutely mad. So these are the patients that are up at the nursing station and they're dying for their next dose and they're bargaining and they want more opioids. It's just on and on and on. because when their internal system is off in that way, when they don't have enough opioids, they feel so on edge and jittery and uncomfortable. And that's what protracted withdrawal feels like. When it's acute withdrawal, as this graph is illustrating, it's it's much more fulminant than that. People have severe abdominal pain, they get myoclonus and jerking of their muscles, lacrimation, tearing, vomiting, flu-like symptoms, kind of the whole 9 yards. And when they feel that starting, those very early stages, they get extremely anxious because they don't want to be that sick again. And so that's why they get so clingy and so difficult in medical settings, because they're really in fear of going through that severe withdrawal again. And the anxiety starts before you see any physiologic symptoms. So patients will look fine, but they'll just be so anxious about their methadone dose or their opioids, and so they drive providers crazy. But it's because they're so terrified of going through the severe part of the withdrawal. It's kind of interesting because alcohol and benzo withdrawal don't cause nearly that discomfort, but those are the ones that can kill you. Opioid withdrawal almost always won't unless you have somebody with cardiac failure or some kind of medical condition where vomiting could alter their electrolytes or something like that. Otherwise, it's not deadly. It just feels deadly to patients. Back in the late 19th century, in the late 1800s, all of this was actually available over the counter. So we've had a long history in this country with kind of what's legal and what's illegal. And heroin was actually introduced by Bayer Pharmaceutical Company. And heroin was their brand name that they came up with. It was because you feel like a hero if you're on it, because it kind of numbs everything for you. And they marketed it as a treatment for morphine addiction. So yet another time, a pharmaceutical company and all of medicine, I think we're partly responsible for this as well. We kind of caused more harm than good. People quickly started abusing it much more than heroin, or much more than morphine rather, and heroin became illegal in, I think, about 1924. So before that time, it was readily available over the counter. This preparation on the left-hand side, laudanum, is a mixture of alcohol and opium, and it was marketed to treat sleepless babies, babies who had colic. Moms were told to take it as well for their own stress. And so you can imagine you had some pretty happy moms and babies, but maybe some babies that didn't wake up, which is not good at all, of course. And this is just a very quick timeline. Opium has been around and has been known about since for, I think, over 1,000 years. It's been an incredibly long time. It's one of those ones that in ancient Sumeria, they were writing about it. So it's always been used as a pain reliever in that way, but it wasn't until the 1800s that the needle and syringe were invented, and you started seeing crises and people getting more addicted. There was a whole Chinese kind of opium era. In the 1960s, there was a heroin epidemic in New York City, but the epidemic that we're facing now is the largest one, definitely in our nation's history, in terms of the percentage of people that are addicted. And in 1914, there was just this interesting Harrison Narcotics Tax Act. I think it's helpful for people to know about. So it was a registry that was created, and the idea was that it was a tax law for passing opium and cocaine leaves, coca leaves, across state lines. And through a series of court interpretations, it ended up meaning that physicians were not allowed to prescribe morphine to patients who were addicted to morphine. And it got very dramatic. Physicians were thrown in jail if they were violating this law. And so it set up this real kind of discord between patients and doctors. And I think, honestly, it's responsible for, if not a lot of, at least some of the stigma that we have today. Physicians in general don't get much addiction education, which they're trying to change now for things like this. But also in medical school, they're trying to introduce it in the curriculum. But just classically, most physicians have stayed away from the treatment of addiction, and there's been just a lot of stigma and a huge divide. The AA and the NA community is somewhat anti-medical community because of this long history. And I think a big part of it was because the government, for the first time, interfered in a physician's private practice with this law back in 1914. There was no pharmacologic way to treat opioid addiction as a doctor up until the 1960s when they introduced methadone maintenance. And in between that time period, from 1915 to 1960s, there was plenty of psychosocial treatments tried. Some very brilliant people did psychoanalysis with jazz musicians and kind of all these kind of elite members of society who were addicted to heroin, who you would think would be able to recover, and they had really abysmal recovery rates. And so just kind of nothing was really helping with people who were addicted to opioids. And so in the 1960s at Rockefeller University, Vincent Dole was able to introduce methadone, and he injected people with 150 milligrams intramuscular methadone, and pretty much overnight they were able to start functioning, go to work. You saw reduced rates of HIV, Hep C, well, not HIV back then, but hepatitis C, reduced crime rates. And so we have study after study after study documenting this since the 1960s, that when you give people medication-assisted treatment, which now includes buprenorphine or Suboxone as well, you immediately see all of these psychosocial and medical indicators start to get better. So the evidence has become very clear over the last century that psychosocial treatments alone are not very effective, but when you kind of substitute the opioid for someone, they're able to get back to a normal life. And we'll talk a little bit more about the pharmacology of that. So just some graphs. So since that time, and I'm sure some of you guys have already seen this kind of stuff, these are non-heroin opioid admission rates, so basically prescription painkillers. And this is the more red the state is, the higher the admission rate. This is in 1999, 2001, 2003, 2005, 2007, and 2009. It's actually higher in 2011, but they changed the indicators because the ratings were not high enough, so it didn't look as impressive for 2011, but the rates have continued to go up. And unfortunately, we'll talk about fentanyl because that's causing a lot of deaths too. And just some other graphs, which I'm sure people have also seen. Starting in 1980, you saw around 10,000 overdose deaths per year. As of last year, it's the highest on record at 64,000. So over here in the upper right-hand corner. And you can see that we're actually above peak car crash deaths in the 1970s, peak HIV in the 1990s. So kind of all of the recent epidemics, death epidemics in recent memory, it surpassed all of those by quite a bit. And these are drug overdose deaths total, but 70% of them involve opioids. So this is definitely being driven by the opioid crisis. We've seen probably around 600,000 deaths since the beginning of this crisis in the 90s, with a $92 billion annual impact. And it's actually reversed our life expectancy. It's been increasing every year for decades. And in the past few years, we're actually reduced by 0.28 years if you look at the overall population. And it looks like it's entirely related to these drug overdoses, unfortunately. And the heroin market has also changed as well. Just a few years ago in Newark, heroin cost $10 a bag, and it's now $5 a bag. I've heard in Patterson it's $3. So incredibly discounted prices here. And unfortunately, New Jersey has some of the purest heroin. Newark specifically has some of the purest heroin in the entire United States because a lot of the illicit heroin coming in goes through the port of Newark. And my patients have told me that drug dealers from New York City will come to Newark to get their heroin. So kind of the farther you go away from the coast or wherever it's coming in, the more adulterated it gets. So if you went to Ohio, for example, you might pay $30 for a bag of heroin and it would be much less pure than what you're getting in New Jersey. Some levels have been up as high as 95%, but the average is around 58%. A few decades ago, the average purity was about 15%. So the same way that we've seen a huge increase in the potency and the purity of marijuana, we've seen the same thing for heroin, unfortunately. So people are getting very pure stuff. And it's increasing in every category that they look at. Fentanyl is the kind of new kid on the block that I'm sure people have heard about. In the past couple of years, it really spiked. There was a tiny spike in 2006 where they found fentanyl in some, it was traced back to a single lab in Mexico, but they had found fentanyl in some autopsies of overdose deaths. But it really took off in 2014, and it seems to be climbing every year for the past few years. So fentanyl is just basically a very potent synthetic opioid, and it looks like it's being illicitly manufactured elsewhere in the world, largely China, and then getting shipped in through the black market trade. The idea, we think, is that drug dealers want to be selling especially potent heroin because then their brand will get more popular on the street and more people will get heroin from them. So they're trying to sprinkle in just a little bit of fentanyl in order to make it more potent, but they're not advanced chemists necessarily, and so they're sprinkling it a little bit too much, and then you see a rash of overdose deaths in that neighborhood. I've actually had patients several patients have told me when somebody overdoses, other people will ask where they got their heroin from, and they'll go to that drug dealer specifically, which is so alarming and tells you their prefrontal cortex is entirely offline, right? But the idea is not, I don't think, on anybody's part to kill people. It's just the drug dealers are dealing with very small amounts of chemicals, and I'll show you, I think the next graph has a picture. So a lethal dose of heroin on the left is that amount. The lethal dose of fentanyl is in the middle, and that's 50 to 100 times stronger than heroin. And then carfentanil has even been popping up, which is 50 to 100 times stronger than fentanyl. So if you can see over on the right-hand side, it's literally like a little grain. So you're talking about extremely small amounts, which is not very helpful if you're making your drugs in a kitchen or whatnot. So incredibly dangerous stuff. The other danger is that fentanyl is just becoming widespread everywhere. So people are actually crushing it into pills. And it's helpful to tell people about this because they might think if they get what they think is a Percocet or an OxyContin on the street, then they're safe. But some of these are actually counterfeit Percocet or OxyContin that are just crushed fentanyl. And there's even been a few overdoses in New York City that was cocaine laced with fentanyl, which doesn't even really make sense because the person is looking for kind of an upper and then you're giving them a downer as well. But it's really just spreading far and wide. So as much as you can to educate your patients and your clients that there's just so much fentanyl out there. And all my patients will say that they see a lot more people slumped over in doorways. They've had so many friends that have overdosed. It was already happening, but the numbers are just really alarming at this time. And just to show you another way to look at fentanyl, it's a little hard to see. Over here in this blue line, right here, this is the fentanyl rise in the past few years, and it's up 540%, so it's a huge explosion in it. And heroin and prescription opioids are down here. So even though opioid prescribing has started to become curbed since about 2011, there is less opioids available in terms of prescriptions. Now we have much more heroin, and we also have a lot more fentanyl in the past 2 years. So we think that's what's responsible for the rising overdose deaths, and that's why we haven't really been able to get a hold of the beast at this time. And in New Jersey, we're seeing the same thing as we see nationwide. So 50% of admissions right now are opioid related. This is a graph just showing, or a chart showing all the different towns in New Jersey. So some of them are the usual offenders you would expect, like the big cities, Newark, Jersey City, Paterson. But there's a lot of more affluent suburbs on this list than you would expect. And this is happening around the country, but especially prominently on the East Coast, that these kind of suburbs that didn't have any problem with heroin a few years ago are now, their kids are able to get heroin in schools, and you're seeing overdose deaths for all these young kids in their teens and early 20s. And so the kind of heroin epidemic has really spread to the suburbs. Unfortunately, this is what got it the media attention. It's already been an epidemic in Newark among the African American community for decades. So it took for it to be more Caucasian suburbs before it got into the media to become like notably an epidemic. But at least we're now talking about it a little bit more. And just another graph for New Jersey, if you look at the people that are dying, nearly a third were 25 to 35 years old. So we're really losing like our young kids and young adults, unfortunately. It's so common to hear a story where somebody goes to rehab, does really well for a few months, and then they're found in the bathroom with a needle in their arm or not, and they just relapsed one time and they died of an overdose death. So a lot of these stories end up as overdose deaths, unfortunately. So we ended up getting here, just to help frame it a little bit before we talk about buprenorphine prescribing. It definitely did start with the prescription opioid epidemic in the 1990s, and this was really the result of pharmaceutical companies getting very aggressive with marketing. And surprisingly, they kind of lobbied the FDA to be able, this is Purdue Pharma specifically, to be able to market OxyContin, which was an extended release preparation, and they wanted to say that it had very low addiction rates. And they based that on 2 studies. This was one of the studies, which is not even a study. It's a letter to the editor. It's actually one of the most cited pieces of literature in all of medicine. It's been cited over 700 times. And it's literally just 12 and a half lines that says, we looked at all of our hospital charts. We looked at 12,000 charts. Only 4 people, it was written down that they had an addiction by the time of discharge. And so we think it's very rare if you don't have a family history of addiction. And unfortunately, they took this and ran with it. This is obviously not a randomized controlled trial. This is not good data, but they pretended that it was and used that as a big reason. This is a really nice article if anybody wants to read about it. Art Van Zee is an internist in West Virginia, and he was just alarmed at all these young kids coming into the methadone clinics there. And so he kind of pieced it together and wrote this really nice article kind of summarizing Purdue Pharma and their marketing strategy and kind of all the ways in which they contributed to this epidemic. There was a huge emphasis on, they expanded their sales force astronomically, and there was a huge emphasis on doing whatever means necessary to get doctors to start prescribing this. So this is just something that came out recently. This was a sales rep who was trying to get a surgeon to prescribe OxyContin but could never get a meeting with the surgeon, and the nursing staff said he loves sweets and donuts. So the rep arranged OxyContin written out in donuts. This is a recreation of it. And the surgeon thought that was really funny, and so he met with him, and then the story is that after that he converted about 4 patients a week to OxyContin. And that sales rep got lauded in his company, given bonuses. Some of them had bonuses up to $250,000. So there just was a tremendous, tremendous effort to kind of market and promote this and get doctors to prescribe more. And I think a lot of it was well-intentioned on the prescribers' parts. It kind of jived right with the movement in oncology that we need to treat pain and that pain was under-recognized. The problem is that the kind of marketing said just jump straight to opioids, don't bother to try other methods first. And around the same time, with the help of the pharmaceutical companies, pain was introduced as the 5th vital sign and became a part of the Joint Commission. It started to be important in patient evaluations and surveys. And so as a doctor, if you didn't give an opioid, then you would get a bad evaluation, and that could affect you adversely in a number of ways. And so prescribers were under enormous pressure to prescribe opioids. And so it really kind of unleashed the prescribing that we saw. And just in terms of the marketing, as you can imagine, a lot of money was at stake. It might be a little bit hard to see. In '96, they were making about $44 million with OxyContin. In 2001, 2002, there were millions of prescriptions valued at over $3 billion. And there have been a number of lawsuits, and they had $600 million fines in May of 2007, but it's really a drop in the bucket if you look at their overall profits, and nobody went to jail, and nobody has gone to jail since then. They also knew that through their own testing that OxyContin could be easily crushed and abused in that way, but they were reporting that that wasn't possible. But back in 1995, their own testing showed that it was, so that's why they got brought up on criminal charges of misbranding. So there was a lot of kind of purposeful misleading on the part of the pharmaceutical companies. There's been some rumblings about doing more prosecutions now. A number of states have sued pharma, but I think we kind of need to think about kind of a federal intervention at this point moving forward and what we're planning to do. And just one last slide on this topic. So if you look at sales, unfortunately, increasing amount of prescription opioids correlates with deaths and with treatment admissions. And so that idea that if you don't have a family history of addiction that you won't get addicted turned out to be horribly wrong. And we have such a large absolute number of people on opioids that the percentage that are addicted, even if it's not a huge percentage, for any drug of abuse, it's somewhere around 10 to 20% of people who use it will end up being addicted and use it kind of in a compulsive manner. And so you can imagine if millions of people are using opioids, that's a very high absolute number of people. It's not the less than 1% that they had said that it was. Drug court has been great in New Jersey in terms of now allowing medication-assisted treatment. And that's been a new thing that came out a few years ago. Before that, people on drug court weren't able to graduate if they were on MAT, which is a big problem. And then in the past year, they also instituted a new opioid prescribing law when people are prescribing for pain. People might have heard of this. And it means you can only prescribe a 5-day prescription on the first visit, and then up to 1 month on the second visit. But you have to have certain things documented in the record and write acute pain on the prescription and all kinds of stuff. And on that third prescription, they need to be a chronic pain patient. So it's pretty heavy-handed. This is actually one of the most strict prescribing guidelines in the nation, but it's backed up by some pretty good data, actually. If you look on the right-hand side, these are in the ED. If someone is given a prescription, if you look right here, this is a 5-day prescription. So if you follow the graph, it's asking what percentage of those people will be taking an opioid 1 year later for the solid line and 3 years later for the dotted line. If you give them a 5-day prescription from an ED, there's a 10% chance in a year that they'll still be taking opioids. But if you give them a 10-day prescription, there's a 20% chance. And it kind of goes up after that. So if you're talking about a full month, now you're up in the 35 percentile range. So it seems kind of difficult to correlate those two things. You wouldn't think if you give a small prescription to somebody in acute pain that they would still end up on opioids. But when we look at the population data, it's very clear that any exposure increases the risk. And so there's a bigger and bigger effort to make EDs kind of opioid-free as much as possible. And when someone's opioid naive, the goal should really be to keep them opioid naive and to try other pain treatments as soon as possible, rather than moving to opioids as the first line. And a lot of times at this point, there's much more awareness of it among the public, and sometimes it's in the prescriber's own head, feeling like my patients are going to be mad if I don't prescribe an opioid, but in reality, a lot of them might do fine on NSAIDs or acetaminophen or something else. I'm going to skip over naloxone just to tell you guys one thing about it. Everybody here knows about naloxone, has had naloxone training, I'm assuming. So it's a pure opioid antagonist. It's a great, I'll say one quick thing about it. It's great to have it available as widely as possible, and the Surgeon General just a few weeks ago came out with a really landmark guideline to say everybody basically should be carrying naloxone, which is pretty striking that he made that kind of pronouncement. And he did it because it's been shown to be so safe to have in the community. It's just a blocker. It does the same thing as what Vivitrol does, so it's just an antagonist. And it reverses an overdose. So if somebody is not breathing, you give them naloxone, it's going to kick out whatever opioid is on that receptor and get them breathing again, but it's also going to put them into withdrawal, so they don't wake up happy by any means. So you don't want to give it to somebody if they're not overdosing, because they'll be in full withdrawal if you do so. There's a lot of new formulations that are available. This is one my patients on Medicaid have been able to get this without a problem at the pharmacy. It was introduced in the past year. I don't know if this is the one you guys are carrying. Okay, so it's really easy. It's just that little plunger. It retails for about $120 out of pocket. And this is Evzio, the auto injector. Have people heard of this one? So it's like an EpiPen, and it has naloxone in it, so you just kind of put it on the thigh or shoulder or whatnot to inject it. When it first came out, the self-pay price was $700. Does anybody know how much it's going for now? It's actually $4,500. And everybody remember the EpiPen scandal? Where they increased it by like 600% or something crazy. I don't know why this didn't become a bigger scandal, because we have this huge problem. We need this as our antidote, and the pharmaceutical companies are gouging us again. Like they started this problem, and now they're going to profit on the solution for it. So it's just kind of, history's repeating itself over and over, unfortunately. Naloxone itself, does anybody know how much that costs if you just get a vial of naloxone? What'd you say? Peanuts, yeah, it's $1. So it's a very cheap medication. This is a $4,500 carrying case for a $1 medication. So it's complete madness. And I think as healthcare providers, we have to be more vocal about this and really kind of make the public aware that pharmaceutical companies are doing this to us again. So law enforcement in New Jersey is now carrying naloxone, and a lot of them are very nervous when the program is first rolled out. But usually people sign on very quickly, because a lot of these officers were standing around giving CPR to people while waiting for the ambulance to come. And so they feel much better when they're able to give the antidote to someone and they can just wake up and start breathing. And so it's been a really good program that has rolled out in Ocean and Monmouth County, and they're supposed to spread it across the state. So hopefully they'll be doing that soon. So let's move on to medication-assisted treatment. I mentioned that they've tried between 1915 and 1960 to treat just with psychosocial treatment, and it was just really poor outcome rates. You just have incredibly high relapses for opioids. If you send someone to an opioid detox for 3 to 7 days, does anybody know the percentage of people that will relapse back to opioids? It's like 90 to 95%. So it's exactly what you would think. And we've all seen that. I think, if you worked in other healthcare settings, people cycle through detoxes over and over. So at this point, there's nothing evidence-based about detox for opioids, but still, for some reason, it continues to be done. But hopefully in the next few years, they're going to end up stopping. So medication-assisted treatment is the idea of substituting the opioid, keeping somebody on an opioid that is much longer acting and has a very slow onset. And so methadone and buprenorphine fall into that category. Buprenorphine is the generic name for Suboxone. And naltrexone is the third and the newest member to this category, and it's the opposite strategy. So it's a different molecule from naloxone, but it does the exact same thing. It's a very specific opioid antagonist, so it just sits there and blocks the receptor. And the idea for this is that you have that internal opioid system. So it doesn't seem like the greatest idea to block that system because you need it as your natural painkiller. But it does seem to be very helpful for some people. There's some people that feel depressed and flat on it and they don't like it, but other people feel perfectly normal. And they think that it might kind of almost kind of rejuvenate your internal endorphin system. And so because you have that blocker, you're going to upregulate your internal opioids, and that maybe that's what helps with cravings. There's only been a few randomized controlled trials for naltrexone, or Vivitrol as the brand name is known. So we have much, much less data than the other two treatments. And again, there's a little bit of a pharmaceutical intervention here. Alkermes is the pharmaceutical company for Vivitrol, and they've been very aggressive in lobbying you guys in the prison system. They're in Washington, D.C., all over the place. Their Vivitrol injection costs about $2,000. Or $1,500, I hear different self-pay prices. And it's a great idea overall, but it's not for everyone. And I think we just also need to be aware that the data is much, much less. We're talking about a handful of randomized controlled trials in terms of long-term outcomes versus decades of evidence that we have with methadone. And less so with buprenorphine, but it's that same concept. So just to kind of run through the options quickly, methadone is only available in these federally regulated methadone clinics, and that's because of the way it was rolled out in the 1960s. It was kind of a pilot program, and they were nervous about using it in the population, so they said it can only be in these designated centers. Unfortunately, that's led to a lot of divide, and so a lot of people in hospitals don't kind of know what goes on in a methadone clinic. It's often they're separate freestanding facilities. And it also creates a culture around the methadone clinic. A lot of people don't like to go to them because there's people selling Xanax and heroin in front. You see people that are abusing their methadone or abusing other stuff nodding off in the front. It's stigmatizing to go to this separate clinic. So there's kind of a whole host of problems associated with that. Other countries have dealt with it in very different ways. In Australia and a lot of parts of Europe, you can actually get your methadone from the pharmacy. And so patients will go every day or every 2 days to get their methadone. So it creates much greater access. So I think we also, kind of as a society, need to think about expanding how we do our methadone, because it's very restricted right now in these federally regulated clinics. And it also means as an individual physician, you just refer someone to a methadone clinic. You can't prescribe it for yourself if it's for an opioid use disorder. If it's for pain, of course you can prescribe methadone, and they do, but if it's for opioid addiction, it's actually illegal to do that. And that all stems back to that Harrison Narcotics Act. Buprenorphine was introduced in 2002 and was really revolutionary because now this is an office-based prescription. So it works just like, and you guys know, have gone through the training, it works just like any other prescription where you come and see your doctor, you get a prescription, take it to the pharmacy, and you see your doctor in a week, 2 weeks, 4 weeks, whatever you'd like. You can actually do 2 refills on buprenorphine, just like you can with other controlled substances. So technically, you could see patients once every 3 months, and there's nothing illegal or wrong about that. And naltrexone, or Vivitrol, is that third one for the opioid blocker. So the whole key with methadone and buprenorphine is that it's long-acting, so it's keeping you in this middle zone. So you can see heroin in the purple. When you first take it, you get this spike and you feel high, and then within 4 to 6 hours, it's already wearing off and dropping you into that withdrawal zone. Whereas these long-acting, slow-onset opioids, like methadone and buprenorphine, they don't give you that huge spike in the beginning, so you don't get high from it. And then it takes so long to wear off, you're still in the comfort zone by the time you get your next dose. When people are first starting on buprenorphine or methadone, which I'm guessing you guys have had experience with here, they can absolutely get high from it because it's an opioid. So if you're going from 0% on your receptors to any amount, that could feel like euphoria and you could have effects from it. But once you start dosing it every day, people become tolerant to it very quickly, and you get a steady state serum level. And the key is that it's just slow onset. So when you're taking your subsequent doses, you're not bouncing up to a high and then dropping to withdrawal state. You're staying right in the middle. So if people are taking it correctly, and with buprenorphine, it's a partial agonist, we'll talk about in just a moment, so you really can't mess around that much with buprenorphine. With methadone, it is a full agonist, so if people can take extra and feel more high from it, et cetera. But most of the people that you see that are nodding or don't look well on methadone are usually messing around and taking different doses day to day to get high, or they're adding other agents on top of it. People use clonidine, Elavil, Benadryl, kind of anything that's sedating that can be synergistic with it, and then they can feel kind of more loopy and high from it. So there are definitely ways to kind of game it and get a little more high from it. But overall, what you're really doing is occupying all those receptors, you're preserving that person's tolerance, and you make it so if they do relapse on heroin, they already have all these opioid receptors filled and they have that tolerance, and so they're not going to die of an overdose death. So I think the number one thing is harm reduction, but the other thing is that it's really stabilizing that opioid receptor system. If you do a slow detox over a couple months, that would be the only kind of right way to do it, and probably even longer than a few months, maybe 6 months or more, to fully detox yourself, because the opioid receptor system takes so long to come back into balance. So it takes probably a year or even more for people to feel 100% better after being on opioids. And these are people that have gone to the addictive stage, so if you only take opioids for a week or two, this isn't going to be true for you. But if you've been doing daily opioids for a while, it takes a really long time for your brain to come back into balance, and people just feel like jittery, on edge, and not quite right. So we think that's why you see such tremendous relapse rates in opioid versus other substance abuse. The only one that's higher is nicotine, actually. Cigarette smoking has incredibly high relapse rates, probably because it's so available, it's like socially accepted. But for opioids, you just don't feel quite right. And so the overdose, the relapse wouldn't even be the biggest deal if you didn't end up overdosing. The problem is just you lose your tolerance and then you suppress your breathing when you relapse. So the idea with buprenorphine is it's a little different from methadone and all the other opioids we talk about because it's a partial agonist, meaning that it activates the receptor at a 40% level. So if you're completely naive to opioids and you take an overdose of buprenorphine, you actually won't have respiratory suppression that's significant. So you can't really overdose on just buprenorphine. That's not true for children. There's definitely deaths of buprenorphine in children. But for the standard adult, you're not going to overdose on buprenorphine alone. So it makes it the safest out of all the opioids, which is why it's incredibly ironic that you have to do a special waiver training to get certified to prescribe it. And the DEA has you on a list, and you have the threat of a DEA visit, and you have to log it, and all this kind of stuff, when none of that is happening with fentanyl, oxycodone, Dilaudid, all these much more powerful opioids that are easily overdosed on and much more deadly. So because it has that partial activation, it's really nice for patients because some of them describe on methadone feeling a little bit fuzzy or it's a little bit sedating for them, where they feel much more clear-headed on buprenorphine. But also patients that have a very severe addiction, they might not feel as good on buprenorphine as they would on methadone. So that's why you want to kind of figure out which is the best treatment option for your patient. I've seen patients using very high amounts of heroin, 30, 40 bags a day, and they do just fine on buprenorphine. But there's other patients that will say they just don't feel like it quite is right. Like they still have cravings and they still need more. And that's because probably it's that partial agonist, so it's not able to get to that level that they need. So those patients would probably do better on methadone. The other key about buprenorphine that makes it interesting is it has a very high affinity for the receptor. It's actually the highest out of all the opioids. So this is where the precipitated withdrawal comes in, which isn't going to be, it's not going to be as big of a deal, I think, in your population. But if people are physically dependent on opioids, then you need to have a certain amount of the opioids fall off the receptors. So their whole brain should kind of be at less than 40%, because when you give buprenorphine, it's going to kick any other opioids off the receptor. And if you have a bunch of full agonists on the receptor that are at 100%, it's going to kick it off and give you buprenorphine at 40%. And that's going to feel like a subjective drop to people. And so they're going to be uncomfortable and in withdrawal. So you need to wait until the person is feeling sick, and ideally test with just a small piece of the buprenorphine to make sure you don't precipitate withdrawal. And if you don't, if they feel a little bit better, then you're good to go, and then you can give them the full dose. So that's the only tricky thing about buprenorphine. And a lot of times patients will come and say, I tried Suboxone on the street and I hate it, it made me really sick. But it's because they didn't really understand the pharmacology of it. And I found that these patients are actually excellent pharmacologists. So if you explain it to them, they really kind of get it, and they know exactly what you're talking about. In the beginning, when buprenorphine was first introduced, they recommended in-office inductions. So you'd have people come, they'd be in withdrawal in your office, you're doing like a scale with them, then they get their first dose, they have to sit there for 2 hours, and you do the scale again, give them another dose. It turned out all that was really unnecessary, and almost everybody just does home inductions at this time. So you just really explain this to people, you give them the prescription, they go home, and they make sure they're sick before they take the first dose. And I've had very few problems. People with very low kind of health literacy and health IQ can get this and do really well with it. So it's pretty easy to do home inductions with people. The one other thing that people always get confused about, buprenorphine, or the formulation Suboxone, has both buprenorphine and naloxone in it. Do people know why it has naloxone in it? Exactly, yeah. So it's very confusing because it's an antagonist that's combined with a buprenorphine, but the whole idea is that it's not available under your tongue when you take it sublingually. So buprenorphine can't be swallowed, and sometimes that happens in the hospital too. People will give like a whole stack of pills, and then the person just swallows all of them. So if you swallow it, it's not effective because the gastric mucosa destroys it. It's not able to get absorbed. So you have to put it under your tongue. The naloxone is in it, but it's not absorbed under your tongue. It's only available parenterally, so if you were to do it IV or inject it. And that idea is that then you're injecting something that's a combination of buprenorphine and naloxone, and it competes for the receptor, so it kind of ruins the high. So when they do studies of people in research labs, they say that they don't like the high as much if it's a Suboxone high versus if it's buprenorphine alone. So that's the reason that all the insurance companies basically switched to saying we'll only approve Suboxone unless a person is pregnant, which in that case you can get the buprenorphine mono product. It used to be called Subutex, but that brand name actually is out of business now, so it's just buprenorphine alone. In Europe, they actually don't make a big deal about combining it with the naloxone, and they mostly just give buprenorphine alone. And they have like a minority of patients, but a small minority, who regularly inject buprenorphine. And those are actually the only deaths that you really see because they'll often inject buprenorphine and combine it with benzos or other things that are sedatives and suppress their respiration. So those are really the only overdose deaths in adults that you hear about with buprenorphine if people are injecting the buprenorphine. So it's probably a good idea to combine it with the naloxone. There's a number of patients that will say, I have an allergy to it, or I have an adverse reaction, I have to have buprenorphine alone, et cetera. I've asked colleagues this on a listserv and everything, and nobody's ever seen a true naloxone allergy. And it's also not supposed to be absorbed under your tongue anyway. So usually you can just kind of educate patients and say it doesn't matter anyway because the insurance is not going to cover it if you try to get buprenorphine alone. And I think the other important thing to think about when you're prescribing medication-assisted treatment, it feels silly to me at this point that we do these like long courses to get you waivered for buprenorphine because it's actually just so simple to prescribe. Because even if they keep relapsing on heroin and even if they use other substances, you still keep prescribing it. Because if they go back to heroin, that's a full agonist opioid, especially for buprenorphine, but for methadone too. Methadone is always going to be less harm. So they're going back to using something more harmful and more difficult to combine with other substances. So there's nothing malpractice or wrong about continuing to prescribe to someone that is repeatedly relapsing. I have a few patients who use heroin every single time I see them. They always run out of their buprenorphine early, no matter what we do, and they've relapsed to heroin by the time I see them. Tried a bunch of different things. They're not interested in going to groups or rehab at this time, et cetera. But I still continue to prescribe for them because it's harm reduction. It's what makes medical sense. And it's not contraindicated if you're using cocaine, alcohol, or even if you're using heroin. So the more kind of time that their brain spends on medication-assisted treatment, the safer they are from overdose and the better outcomes you see. So you don't want to cut someone off from treatment if they're not doing well. So let me just stop there and ask questions. Well, yes?
The question, so you think there's a benefit from the neurobiology of having Suboxone even in the context of somebody who's struggling and using other meds? You think that it's still helpful in the anatomy of the brain, if you will, neurobiology of the brain?
So just for the recording, I'll repeat the question because I think everyone heard. But the question is it good for the neurobiology of the brain to continue prescribing the Suboxone or the buprenorphine even if they're actively using? So that's not so much a neurobiology question for me, the way I think about it, because you're only going to get that neurobiology to start to repair itself when the person is abstinent from those substances that give them that shock of intoxication and then drop them into withdrawal. So that cycle of like quick high and drop, that's what creates all those brain circuits that become so dysregulated. So when you're on an agonist treatment like methadone or buprenorphine, you do see the neurobiology, all those markers get better, their stress hormones get better, so their brain does heal even when on it. If people are using heroin still, their brain's not going to be healing as much. You know, less heroin is better than more heroin, et cetera. But more I'm keeping them on buprenorphine or methadone at a clinic because if you take them off, they're much higher risk of an overdose death. So it just shows that the more you can keep people and get people in treatment, the better their outcomes are. So any amount of treatment is better than no treatment.
And so, along with that, your notion is it's important to reduce the risk of a death through overdose.
Exactly, yeah. So the question is, it's important to reduce the risk of a death through overdose. Exactly. Roseanne Scotti, I don't know if anybody knows her from Drug Policy Alliance. They're this group in New Jersey. They do some really good advocacy work. But she points out that harm reduction is really just standard medical care. When we have people who are diabetic, we don't come to them and say, fix your diet first, and then we'll talk about insulin or whatnot. We treat them with insulin no matter what's going on. And so I think there's something so personal and emotional about drug addiction, and I think it's because these people's behaviors are so out of control, and so our prefrontal cortex gets activated, and we want to kind of wrestle them into doing what we want and get them to fix their behavior, and there's all these like emotional and psychological things going on. But if you just step back and look at the picture, this is a person with dysregulated circuitry that's struggling. We know that this medication helps their brain come back into balance and protects them, so why wouldn't we be giving it? So it's really only in addiction that we even have the discussion about harm reduction. Everywhere else in medicine, we just call that medical care. We don't discharge people for being non-compliant.
Are there rules, like the state rules for, with buprenorphine and methadone? Like, for example, the patient goes to the methadone clinic and or getting buprenorphine. If he's using cocaine, Klonopin or anything else like that, a lot of times they'll take them off or detox them from the methadone and or buprenorphine.
Yeah.
Is there a way around that, or is the state trying to make less rules for this? 'Cause
Yeah.
what you're saying makes good sense.
Right. So the question is, are there state laws or laws in place that in methadone clinics, it's a common occurrence that people will be using other substances and they'll get a fair treatment hearing and so number of tries, and then they will administratively discharge people and take down their methadone. That's not evidence-based or science-based at all. I actually don't know, I don't know enough about methadone clinics, so I don't know if they're following any state laws or federal laws, but
It appears they are.
I don't know if they are, if the methadone clinics are making that decision. It might be that they are. If they are following laws, they're incredibly outdated and unhelpful. But I think that's part of the problem, that we have such segmented addiction treatment. So methadone clinics and a lot of rehabs and other addiction treatment centers are often run by people who, physicians have very minimal involvement, and so it's run by counselors, social workers, and a lot of other disciplines. And a lot of those people, just the way it's developed over the years, they come from the 12-step tradition, so Alcoholics and Narcotics Anonymous and whatnot. And it has a very kind of anti-medication approach and more of that old school like confrontational approach. And so a lot of these programs grew out of that. And they're not, unfortunately, we're not at the point where they're incorporating enough of the science and the evidence base. And so now rehabs are starting to move toward offering these treatments, but they really need more. We kind of have to have a lot more, I think, involvement as a community overall of what rules we have in what places. Because when methadone clinics are kicking people out of treatment, you're just increasing their risk of death. And of course, you want to help people if they're using other substances, but stopping treatment is the last thing you want to do. They need more intensive treatment, so you shouldn't punish someone by having them evicted from treatment. So it's definitely not good.
We've not made in our guideline psychosocial treatment be required in order to get MAT. And I know you didn't show that in your slide. But
Yeah, I can go to it, yeah.
Schwartz's rebuttal. And so that's where we are based upon the literature. What's your opinion also?
Yeah, so that's a really interesting question, the question of psychosocial treatment in medication-assisted treatment. So as I was saying, psychosocial treatment alone doesn't work. There's been a number of studies where they try to look at, does psychosocial treatment added to medication-assisted treatment, does that make a big difference? And there were several trials that they were arguing that it does. The one that you're talking about is a commentary from Schwartz that was kind of rebutting that and saying, if you kind of take apart the data in all these studies and look at it, it looks like the effect of psychosocial treatment actually fell out and didn't really contribute to it. And there's interesting studies like people who are on a waiting list to get into a methadone clinic, if you just start giving them methadone and they don't have any of the other benefits of the methadone clinic, they do much, much better than other people on the waiting list that aren't getting methadone. So there's a lot of kind of studies showing that where if you just give the medication with nothing else, you still see vast improvements. I would say that that's definitely true overall. And I think, and he has kind of strong language here he's saying physicians should be encouraged to use these medications for their opioid addicted patients and not be discouraged that they can't address all the psychosocial kind of stressors going on with that patient. And if we practice medicine that way, then many patients wouldn't receive medical care at all. So it's that same idea of like you're diabetic, you're going to give them insulin even if you don't think they're going to be great about taking it, or they don't live in a good neighborhood, or they have a donut shop around the corner. None of that is going going to stop you from prescribing insulin. So his argument was the research shows just giving medications alone is probably just as good. Psychosocial treatment added to it, especially for people with co-occurring disorders, with trauma, with psychological issues, of course that's going to be better than no psychosocial treatment. But his argument was don't withhold it if you don't feel like you have robust psychosocial treatment to offer the person. So you guys are dealing with inmates who, just by being in prison, they're already going to have trauma. It's an incredibly stressful environment. So I think all of your patients would benefit from psychosocial treatment, but if it's not available in that prison or in that section, I wouldn't withhold medicated assisted treatment from it. Yeah.
There has been considerable evidence in support of buprenorphine for pregnant women with the neonatal abstinence syndrome outcomes. And we're starting to, I'm probably the only female person, I am the only female person within our New Jersey system, so I get pregnant women who have IDDA histories and are coming in on methadone usually. But there's a little bit of a paradigm shift now where women are starting to come in on Suboxone. However, there are women who come in on methadone who would rather, that's, Subutex. There are women who come in on methadone who would like to be transferred over to Subutex. And I am in search of resources to potentially help. I mean, would it be safe to make that transition? How difficult is that transition?
Right.
Are there resources to help you with that?
Right. So the question was about switching from methadone to buprenorphine when the person is pregnant. That's a very tricky issue, so we didn't talk much about it, but methadone being such a long-acting agent, it's actually really difficult to switch to buprenorphine. And every time I do it in someone, I get dinged and I'm reminded that you have to wait longer than you think you should. It's just incredibly long-acting. So what they normally say for a methadone to buprenorphine transfer would be to slowly taper yourself to get down to about 30 milligrams a day, and then you can stop abruptly, and you wait anywhere from 72 to 96 hours to give that first dose of buprenorphine. But I've seen people who look like they're in withdrawal, feel like they're in withdrawal, and they get a dose of buprenorphine, and it precipitates them, and they get even worse. So sometimes you have to wait longer than you would think, and then at that point, you're using clonidine, clonazepam, Valium, whatever other agents you can to kind of help the person get through that transition. For pregnant women, it's even more difficult because now you have a fetus and a baby that you're worried about. So what they officially recommend is to do all those sorts of transitions in the second trimester. In the first trimester, you have an increased risk of miscarriage if you have the woman going through withdrawal. And in the third trimester, you have an increased risk of early labor, of like kind of starting contractions in labor. So they recommend any switches like that should happen in the second trimester. But the biggest recommendation would be just not to mess with it and not do it, because anything the mom is experiencing, the baby is going to experience it even more. And so there's a huge push to get them on medication-assisted treatment, but they should stay. If they're on methadone, they should try not to switch to buprenorphine until after the birth. If they're desperate, then I would at least wait till the second trimester and just try to do it really slowly and carefully. For people that are prescribing, a really helpful resource is PSS. I think they're PCSS, and I think it's now.org. But if you just Google PCSS buprenorphine, it will come up. They had several different websites, but they kind of collated everything together. So it's in combination with American Academy of Addiction Psychiatry and I think American Society of Addiction Medicine as well. It's an amazing website. It's got so much clinical guidelines and resources, and they actually have discussion boards and forums and an Ask the Expert question. So if you're struggling with a buprenorphine question, you can actually go onto that website and ask an expert who will get back to you and email you back, or even look in discussion boards. So I encourage you to try to use that as a great resource.
Is there any people that you treat in your practice that you are less likely to give Suboxone treatment, or after a while would cause you to take them off?
So the question is there anybody in my practice that I'm less likely to give buprenorphine treatment to, or that I would take them off? Actually, no. And I treat a very sick population, so I take people directly. We're talking about Newark University Hospital, so it's a public hospital. I take people from the emergency room. People walk in that are drinking, that are drunk that day, actively using, shooting up, the full 9 yards. I offer everybody buprenorphine. I haven't run into even a medical condition that would contraindicate the prescribing, because on the consult service in the hospital, sometimes we see people with liver failure, cardiac failure, stuff like that. And buprenorphine, fortunately, does not prolong the QTC. So we've seen cases of people on methadone who had to abruptly stop their methadone. They can get transferred to buprenorphine, no problem. Even if their QTC is 600, you would still give buprenorphine. And even in liver failure, you can give small doses of buprenorphine. You're just like more gentle with the dosing, but it's still indicated for those people. So I haven't run into anybody where medically or psychiatrically I've said that buprenorphine is contraindicated. And I've had patients that I never would have expected would do well come back, and I'm so busy at this point, I'm often seeing a person once and potentially not seeing them for 4 weeks later. So I might meet the person and give them a prescription for an entire month, and someone I never thought was going to come back comes back right on time, and they may have relapsed, they've had slips here and there, but they're engaged in the treatment and they're doing well. People that live in abandoned houses, they're chronically homeless, kind of people you wouldn't expect. And part of we didn't discuss this part, but part of the problem with buprenorphine in the larger picture is that it's become demographically divided, where if you're a higher socioeconomic status, you have access to bupe, and if you're lower, you have access to methadone. So there's very few Medicaid buprenorphine providers in Newark, despite this huge problem. And I think hopefully there needs to be more incentives for people on Medicaid to have access to these providers, because they're all kind of just shuttled to the methadone clinic, and many of them don't want to go for a variety of reasons, not the least of which you have to go 6 days a week. So it's a tremendous drain on your resources to like get yourself to the clinic every day. So we need a lot more kind of branching out and having buprenorphine available to everyone, because every population, it seems like, can do well on it. And I never reduce the dose. I never try to get anyone off. I don't even really talk about it with people. When people talk about it with me, I just try to tell them the research and say, if you want to get off of it, let's go really, really slowly. And I will say it is hard for people to get off buprenorphine because it has such a high affinity for the receptor. They get down to like the 1 milligram, even half a milligram dose, and it's hard to get to 0. So that's the kind of sad part of this, is that you're signing them up for pharmacologic treatment that could be difficult to get off, but the data is just so clear that they have such a high risk of overdose death. That's why we push it so much. And you could tell I'm not a fan of pharma, so I never do anything with buprenorphine pharmaceutical companies, nothing like that. It's just clear that that's the best option, but I do feel bad for those patients who really struggle to get off. And if people do get off, you want to put them on Vivitrol and try to convince them as long as they can to stay on Vivitrol. The idea is to keep that receptor occupied just really as long as you can.
First off, thank you for the very effective overview.
Thank you.
Presentation. Very good. Can you talk about where you see Sublocade in your armamentarium treatment?
Yeah, so the question is about Sublocade. So for people who don't know, Sublocade is, I think it's officially approved now, right? I think it's recently approved. It's a depot injection for buprenorphine. I think it's brilliant and awesome. I think it's a great idea. And for these patients that I'm worried that, there's definitely some patients that are diverting buprenorphine. And I would say the biggest thing I do in my practice is get occasional urines to make sure there's buprenorphine in the urine. And I'll tell my patient, I want to keep prescribing for you, but I have to see buprenorphine in your urine. So, there's definitely patients that are diverting. So Sublocade is a great option for those patients that you think are at high risk for diverting it. As a side note, I'm not against buprenorphine being available on the street because nobody's really using it as their drug of choice. They're using it to stave off withdrawal. But Sublocade in general is also perfect for a prison population if you're worried about people cheeking or passing it to other people and whatnot. So I think at this point it's expensive, and there's all kinds of regulations with storing it on site at your office. And so all that is kind of being hammered out. I don't know anybody who's using it yet. But I think it's going to be, once we kind of figure out all the regulations and people get comfortable with it, I think it's going to be tremendous to use that.
What about in the cases you talked about patients that are also using heroin while they're prescribing Suboxone? Would they be candidates?
Yeah. As far as Sublocade is going to be, anybody who is a candidate, as far as I'm concerned, for oral buprenorphine would be also a candidate for Sublocade, because I'm trying to keep buprenorphine on the receptors as much as possible. And when they're using heroin, if they're on buprenorphine, they're not going to get as much of a high from it. It's a much attenuated high. But I'm sure some of those patients are stopping their buprenorphine for 5 or 6 days, using heroin, going back and forth, and they'll describe that to me as well. So Sublocade enables you to keep it on the receptor the whole time, so they're going to be much more protected from an overdose, and it's better for their recovery, because now they have less and less reinforcement from heroin. No matter what they do, they can't get that high, and that's very helpful to extinguish the behavior.
And lastly, those patients that you are recommending Sublocade for, who
So if patients would refuse to take the Sublocade. So I haven't thought about that because I haven't encountered that clinically yet. I think that would clearly be an indication that the person is diverting. So then I think you'd have to have a whole other conversation to figure it out. But I haven't thought that much about that. I tend not to worry a lot about diversion, and I have had a DEA visit. It was actually not scary at all. I've heard some could be quite scary, but this one really wasn't difficult. Their biggest issue was, they didn't even care if I had a bona fide relationship with the patient, which I thought would be their biggest thing, but they didn't ask to look at any charts. They wanted to make sure I was keeping a log of prescriptions, and they wanted me to photocopy every prescription, and I was like, I really don't want to do that. So they said you can write down the serial number on a log sheet, so I just have this log where I put the serial number, but that was honestly the only thing, and they wanted to make sure I knew what my current limit was. So at that time I was at 100, and they wanted to say, how do you know that you're treating less than 100, we want to see all the charts in one place, and I had to move them all to one folder or something like that. So those are the only things they were really interested in. So from a medical legal perspective, I don't think it's going to be that big of a deal, but that would increase your concerns about diversion if somebody's refusing the Sublocade when it's an easy option versus the oral.
Where is your clinic, and can you describe the demographics of your patient population?
Yeah, so my clinic is in Newark. So it's unfortunate because a lot of Newark, there's drug spots right around, but I have patients that some travel to me from outside of Newark, and they say it's very triggering to come to the office because there's like 5 people selling drugs all around. But my demographic is really a Newark demographic. Most of my patients are from Newark, so almost everybody has Medicaid. It's largely African American, a smaller component of Latino. I would say 60% male, 40% female, and the majority of people are 40s and 50s. I tend to see the kind of Newark population that has already been using heroin for years and years and years, so they're not the prescription pills that are part of this recent epidemic. Some of the patients have been sniffing heroin, 5 bags a day for 35 years, and they've decided to get into treatment.
Do you know what percentage have been in jail or prison?
An incredibly high percentage,
So
probably
they're
40%.
likely to be our patients.
They're your patients, yes. They're your patients, yeah. I should have just said that. That's the easy way to say it, yes.
Well, no, I mean, I think sometimes
Yeah.
for some of our difficult people, we think they probably come from out of the sky and just fall into prison.
Right, no, yeah.
Forget that they're part of the real world.
Yes, yeah. No, it's unfortunate because I frequently have patients that miss appointments and they come back and they say, I was in jail, I was picked up on a warrant, I had this, I couldn't make bail, like all kinds of, it's just really sad, and it interrupts their treatment and it screws up kind of all kinds of their housing.
How long have you been?
So I graduated from my addiction fellowship in 2012, but I came to New Jersey in 2014, so that's when I really started prescribing more buprenorphine. So I've had this clinic for the past 4 years, and now I treat about 160 patients, and I see patients 2.5 days a week, so I'm like more and more squeezed. We're actually hiring a counselor and kind of expanding, because a lot of my patients, they have like a girlfriend, a mother, a nephew that wants to come too, so it
And
gets
you're a
kind of
younger
difficult.
person. I'll speak for myself. I'm not so young. But many of us are, from a variety of ages and experiences, and I think not many of us are as young as you and have had a similar approach. I mean, you have an addiction fellowship, with the exception of Dr. Bramley. Not to, I'm proud of you of that. But what I'm saying is, I think many of us are struggling with this whole notion. That's all.
Yeah. I mean, I should have said that at the beginning because I think I'm treating the same population that you're seeing in the prison. And it's a population that can do better than you would think. And of course, there's manipulating and lying and diverting and stealing. But overall, these are people that I see getting their life back together. They talk about having money in their pocket. They're able to kind of do day-to-day things. There's much larger social issues. It's very hard for these patients to get jobs and to build stable family lives. There's so many other factors going on. But just by providing them buprenorphine, and the biggest thing, a lot of my patients will say they're so grateful to wake up in the morning and not have to be sick. Because if you're addicted to heroin, the first thing you think of in the morning is the heroin there that I left from the night before? Or, oh crap, where am I going to get heroin from? And you see people going out and committing crimes and mugging people and robbing and all kinds of stuff. So I think the biggest thing of all is taking away that monkey on their back, that they don't have to have that constant enslavement to it. Yeah. Oh, it's okay, either one. Yeah, so basically the question is, it's kind of how do you help people out of poverty, right? So that they're like not able to work, they don't have stable housing, all that kind of stuff. So I think about it a lot, it bothers me a lot, and I feel like I'm not doing enough for my patients, especially when I'm squeezing in so many, such a huge need. I'm seeing patients in less and less time, and I'm giving them this prescription. They're incredibly grateful for it, and so a lot of times just from their interaction with me, they show me that they really appreciate whatever time I'm able to give. But I think it's much bigger than us. I think we have to take a societal look at what's going on. There's tremendous income inequality. Just the fact that the majority of people in prison are African American, and they get arrested at 4 times higher the rate of Caucasians when they're all using the same amount of drugs. So all that data is incredibly clear. I think there's like racial and social entrenched issues that we all need to deal with as a society. So it's bigger than all of us, but I think the big idea of this Schwartz article is to be like, don't let these huge systemic problems of poverty stop you from doing whatever you can do as a provider in that moment. So I don't have any magic answers for that kind of stuff, but I think prescribing buprenorphine is at least a starting point that is worth it in this population and can make a big difference.
When you prescribe the buprenorphine, Suboxone, is there an average dose, or is it very, very individualized?
So the question is there an average dose for buprenorphine? When I first started out, I would frequently prescribe up to 24 milligrams, and then I kind of realized it was probably a little bit of overkill. You do see higher diversion rates at 24. So what they found is kind of the sweet spot is right around 16 milligrams. So almost everybody, and you'll see this when you check prescribing, if you check the PMP and whatnot, almost always if you have somebody that has another Suboxone provider, they'll be getting 8 milligrams BID. So like the kind of standard run-of-the-mill dose is 8 milligrams twice a day. It is a once daily medication. It has a half-life of 24 to 60 hours, so you can absolutely dose it once a day. But heroin is a very short-acting medication/drug, and so people normally dose it 3 to 4 times a day. So all my patients, like if you try to dose it once a day, they start feeling some withdrawal symptoms in the evening, et cetera. So everybody wants to split it BID, so that's the normal way. And I have a chart in here just showing at 16 milligrams a day on an average person in their study, 92% of the opioid receptors were occupied. So at increasing amounts at 24 milligrams, you're going to get a little bit more, but we're talking about just a small percentage more occupied. And then I had one patient that came in and felt sick at for 1 week. He took 9 strips a day, so 9 times 8, 72 milligrams a day for several days, and ran through his whole prescription in like 4 days, and then came to me desperate what to do. I think we were able to get him an early refill or figure out something. But it's really helpful to educate patients that you're just throwing it away at that point because it's a partial agonist. So you're going to fill up all the receptors in your brain. Over 24 milligrams a day, I've never seen that as clinically needed or necessary. I did prescribe 32 milligrams for this one guy that always used heroin when I saw him, and I put him on 24 milligrams, and I saw no difference whatsoever. So I think 24 is really the max. Most people will be fine at 16. If you're in incarceration, if you're in a prison setting, 2 milligrams, 4 milligrams might be fine. When they're ready to go to the community, I would at least give them 8 milligrams as they're leaving because 2 and 4 milligrams is too small of a dose to really, there's not solid data on this, but I feel like it's too low of a dose to really make sure that you're going to help with overdose death rates. And so I'd want to at least give them 8 milligrams to get enough of those receptors occupied. And I have a lot of people who in the hospital can take just 8, but when they go back to their neighborhood and all the cues are in front of them and all the triggers, they get cravings. And so 16 is like kind of a more safe dose. So I would say almost everybody is 16.
Quick question. Is the university going to be offering a fellowship anytime for anyone else who might be interested?
Thank you. So the question, it's like a plant. She's like, is the university? I swear I didn't put her up to it. So the question was about an addiction fellowship in the future. We actually got approved to do an ACGME fellowship because addiction medicine just became an official ACGME specialty in the past just a few months ago. So we're actually going to start an official fellowship where you have to come do a full year at our institution starting in July 2019. So I encourage anybody to apply if they'd like. And unfortunately, because of that, we're not doing the more flexible fellowship that you participated in. But we do have a new program that you guys should know about. It's called ECHO. And they do these virtual webinars, and you have access to a mentor. And Petros Lavonis, who's my chair, some of you may have met him, he's also an addiction person. So we're both on like the addiction team. So I can pass the info to you, and you can circulate it. Because I keep forgetting to advertise for it because the dates aren't set yet, but it's probably due to start this fall. But it's basically a series of addiction lectures online, and there'll be ways to participate and ask questions and whatnot.
what, are they using Zoom? Do you know?
I don't know which format they're
Oh.
using. UBHC is taking care of everything, but they've recruited us
Okay.
as like the addiction
'Cause
people. But I'll,
some of us have participated in the ECHO on diabetes and.
yeah,
chronic
right.
disease.
This is a new addiction program
Yeah,
within ECHO.
The
Yeah.
downside of it
Is it firewall or something in the prison system,
yeah,
or?
in the prison.
Oh, so you
but,
can't watch it at work.
But
That makes
we
it
can
difficult.
figure out
Okay.
something.
Okay.
But that's unfortunate, you're not gonna have that program that Dr. Brainbridge was able to participate in.
Yeah, we had this flexible fellowship where we had kind of 6 lecture series and then other lectures throughout the
Yeah,
year.
right.
But I think the ECHO program is actually going to be even more convenient for people because for the other one you had to come to our campus, and so if you're, and also it was Rutgers specific. So I think this will actually reach more people.
Okay.
So I'll definitely share the information with you.
Yeah, please do.
Yeah.
Because maybe we have laptops, so maybe we can all.
Yeah,
meet
just bring your home
somewhere,
laptop
right,
and plug
yeah,
it in.
and do it.
Yeah.
Yeah.
I saw another hand. Yeah.
If I had a patient who comes to me asking for Suboxone but is leaving in 2 months, so how do I handle that?
So the question is, if you have a patient coming asking for Suboxone, but they're leaving in 2 months and not right away. So that's a larger question, I guess, for all of us to have a discussion, because I'm not sure, I don't know the level of drug use, like if you're seeing opioid overdoses for people, if they're not maintained on anything, because if they're on buprenorphine, they're going to have less risk of overdose in the prison population
Yeah.
itself.
Yes, we are seeing drug overdoses.
You are? Okay.
And Dr. Reddy has the pleasure of working at a site where there are halfway house people.
Oh,
So-
are they out in the community?
Yes.
So if they're able to go outside, I would try to get something on their receptor, whether that's Vivitrol or buprenorphine or whatnot. So anytime someone's exposed to the drug, then that's a potential overdose. So if in any way they're able to get drugs or anything, I think you should try to put them on it. People go through that protracted withdrawal syndrome, so also they might be uncomfortable for a really long time. So it would be nice to have people just maintain throughout their entire prison stay. I don't know the logistics of all this, but just medically, I think it's always appropriate to start medication-assisted treatment. It would just be logistically within the system
Now,
if there are
Dr.
problems.
Reddy, are you talking about how to start it or the logistics or?
We're more concerned about the follow-up on once they
Yeah,
leave.
okay, so, and we have Micah Hillis here, who's gonna follow her, who and his program would be able to assist us in initiating people and continuing to be sure that they get follow-up upon discharge. So Micah Hillis will be talking shortly.
And even as a worst-case scenario, if you're not, because I know in some areas and counties it's harder to link up with a treatment provider, methadone clinics, if they're available, often have a cohort of people on buprenorphine, so you could always refer to the methadone clinic and they could continue their bup there, or they could be switched over to methadone. So I wouldn't worry as much about the treatment providers, because in the end you can always say, go to this methadone clinic, and methadone clinics usually are happy to have relationships, or they'll accept new admissions.
Oh, they will accept somebody on buprenorphine?
Yes, you can't guarantee that person's going to stay on bup. They might switch them to methadone,
Oh,
but
at
it's,
least,
yeah, they have
Yeah, I think-
limits. Like, oh, go ahead.
I think the biggest concern is that we're putting people on a drug and then we're feeling some responsibility about them. So
Yeah,
I think
yeah, and
I
as
would be
yeah,
okay with them going to a methadone clinic as opposed to not being able to go anywhere.
right,
and get
right,
follow-up.
right. I should have mentioned this one part because it's important for your population. If you're released from incarceration, you have 129 times the risk of overdose death compared to the general population. So your people are the people that are at the highest risk. Another really high risk group is people who are at rehab, who are completely abstinent for 30 days or even worse for 90 days, and then they leave and go back to the community. But some of your people are, 5 years, 10 years, however long, and so their brains are perfectly pristine. So those are the people you want something on their receptor when they walk out. And if you're worried about, that they're not going to be able to get follow-up for buprenorphine, then you could consider Vivitrol instead, because that's just the blocker. And there was recently a study that was released in the criminal justice population, which I can send if you want to pass around to people if they're interested. And that one showed that in the Vivitrol group versus the non-Vivitrol, that the non-Vivitrol had 7 overdoses in the 78 weeks that they followed them, whereas the Vivitrol group had no overdoses. And of course, a bunch of people in the Vivitrol group never got their second injection. So some of that early data looks like it helps protect you in that very scary time when you're first back in your neighborhood. And so they're maybe frantically trying to use heroin and it's not able to get much to their receptors. So as the Vivitrol wears off over that month, then it gives them a much softer landing for their receptors so that they're not going to flood them and end up overdosing. So if you're worried about that, maybe to do Vivitrol instead.
And that's what I was going to talk about, the Vivitrol, because we have some reentry halfway house facilities, and the residents So they get the first dose, and then they're released to the community, and as you were stating, do they come back, do they get their second dose after 30 days or not?
Yeah.
I wanted to get your opinion on that.
Yeah. So the question about Vivitrols and whether or not people get that second dose, that's the hardest part about Vivitrol. Suboxone and methadone are both going to give you a chemical hook in a way. And then sometimes I almost feel like I'm now the new drug dealer, because my patients are like clamoring to get Suboxone from me. I'm like, it's not unlike knocking on the door of a heroin dealer, right? But Vivitrol doesn't have that hook at all. And so the biggest problem is getting people to stay on it. I've started a few people on Vivitrol in the community, and they've all fallen off for one reason or another. It often is more motivated people who have usually family that are pressuring them, or they're really internally motivated and they want to stay on it because it's literally not doing anything. So they'll just say, oh, I don't need it, I'm not going to relapse anyway, or whatever it may be. So it is hard to get people to keep taking the Vivitrol, but the part you're worried about is right when they're getting back to the community. So our early data, the little data that we have, looks like it is protective. So I would try to give that first dose to everybody and not even worry so much if they're going to follow up for the second one. The most important part is that there's something on that receptor when they walk out the door. Okay. Oh, do you have one last question? Sure.
Is Vivitrol going to be covered by like any of the insurance companies versus or Medicaid?
Yeah, you mean Vivitrol, right?
Yeah.
So the question is Vivitrol covered? I treat almost all Medicaid, and I've gotten it covered on every company. Yeah, so all these medications, well, methadone's really cheap, and you have to go to a methadone clinic anyway, but buprenorphine and Vivitrol have been covered by every company I've ever worked with. They're super difficult with prior authorizations, and that's another annoying part of it, that you have to do a lot of prior auths, and sometimes it helps to have other staff to help to do with that. But once you get through the prior auth process, everything's covered. Yeah.
You have to make that part of your fellowship. How to get
I know.
patients.
I know. I hate talking about the prior auths because it scares people away from doing it, but the prior auths are arduous.
Today, Sublocade was just added to the Medicaid formulary.
Oh, it was. Sublocade was just added to the Medicaid formulary, so I hadn't heard that. That's great. That's great. So I'll have to look into that then, start prescribing it.
Well,
All right. Thank you, everybody.
wow, this was pretty amazing.
Thank you.